Live. My name is Dr. Tova Goldfein. This is TMS Roundtable Recovery. We have been streaming live weekly for a long, long time, and I am so happy that we got Dr. Lumley to join us. It's been a little bit of ebb and flow, but you're here, and Yohav Bar Yosef is my co-host tonight, who is a pain psychologist in Asuta.
Not anymore, in Ichilov, in
Ichilov,
Tel Aviv Center, yeah.
An amazing hospital in the Pain Psychology Center, and has a private practice. And him and I have been like missionaries in this work. We bought Pain Brain, we bought This Might Hurt. We have been involved with a wonderful community of doctors and therapists here that are really applying this work. And your name comes up, EAET comes up, and emotional awareness, expression therapy. And so we're going to talk more about that. But I want to just say a few words about this, about you, Dr. Mark Lumley. You're a clinical psychologist, a distinguished professor in the Department of Psychology in Wayne State University. And you're doing research, which is almost like a research about emotions. Check. So, yeah. And what's wonderful about having you share the studio with us is that you really have a lot to say about emotions, the brain, and the direct effect on healing chronic pain and autoimmune symptoms and fibromyalgia, which is a buzzword. People are struggling and suffering. So I would love to hear some details about your life and what brought you to this. Like, why this genre? It's something drew you and keeps you here.
Well, it's delightful to be here. Thanks for the invitation, Tova and Yohav. Hello to all my new friends in Israel. I guess it's evening there. I'm calling you from Detroit. Behind me is the waterfront of Detroit, the downtown area. And Detroit is the home of Wayne State University. Nobody's ever heard of Wayne State University, so it's in Detroit, Michigan, up in the north of the United States. I hope there's a few other folks scattered around the world who might be joining us this evening or this afternoon.
Doesn't Dr. Schubiner live in Michigan?
Yeah, we're neighbors, just 20 minutes away from each other.
Wow, amazing.
So you asked how I got into this stuff. Everybody's got a story, don't they?
I want to hear details.
All right, so starts at my earliest memory of something relevant to mind body was I'm an elementary school student taking a little science part of my 4th or 5th grade, and the teacher was showing a video or a movie, back in the day, a movie of dialysis happening, where the blood is flowing in and out of somebody's arm, right? And I'm watching this going, this is fascinating. This is fascinating. I don't feel so good. I got into the bathroom. I got up, I walked out of the hallway, and I barfed right there on the floor. And I remember slouching against the lockers, sitting next to a pile of my puke, and it was ashamed of myself. And I remember the janitor walking up and, what's up? And I'll clean this up. And I remember thinking to myself 2 things: how embarrassed I am. And then, how the hell did that happen? That something went in my eyeballs and worked up something that came out of my mouth, And I remember thinking, this is fascinating. How can this be? That just watching something or whatever. And I actually had sort of a vagal syncope, blood phobia, injury stuff. And so the notion of fainting or getting lightheaded around broken bodies was always sort of there in my development. I was going to be a physician. I went to college to be a physician. And I became, I was studying both psychology and medicine and debating between the two. And I ended up going into health psychology, which is like medicine applied to psychology. In part because I didn't really want to do the whole medical route thing. In part because I wasn't really fond of, cutting up bodies and such. But it was other pieces.
It's called dissecting a cadaver.
Yeah, but then there's live ones too, and called patients. But mostly it was psychologists really enthralled me with how the heck is the stuff above here affecting the stuff below here, And so I pursued it. Now, what's an interesting story is when I became a graduate student in my doctoral program, University of Florida, there was a pain psychologist there who basically said, I hate pain patients. They never get better. They complain. I can't do anything to help them. don't, stay away from pain patients, Mark, stay away from pain patients. And I did. I avoided pain patients all throughout my training. And I worked with anxiety and other sorts of issues, but not pain. Until a little later in my career, I ran into a psychiatrist who introduced me the idea of alexithymia, which is this word which means lacking words for feelings, literally, alexithymos. And it's this idea that within some people, they have difficulty knowing what they're feeling, putting it into language, expressing it. And that seems to be a risk factor for pain and stress problems and lots of other health issues, including behavioral problems like substance abuse and the like. And that led me down a new path of maybe I could tackle the emotional stuff, which I've always been interested in, and apply it to the pain world. And when I became a professor, a junior professor 30 some years ago, I ran into a bunch of students who were interested in pain problems, sickle cell disease and non-cardiac chest pain and rheumatoid arthritis and others. And that led me into moving back into this pain world that I'd not pursued. I'd been pushed away from when I was a little younger. I'll just wrap up the story with another piece. We studied alexithymia. I did a bunch of research projects on what is alexithymia related to. Most everything bad is what it's related to.
Again, explain it because there's some new listeners. What does that word mean?
Alexithymia, which is this word that was put together back in the 70s. It really means lacking words for feelings. Lexicon.
I think the majority of human beings have that condition.
To some degree, most of us don't talk about feelings because we're suppressing them or blocking them, something I'm sure we'll get into today. But there's a subset of people who are really, truly confused. They don't seem to have mechanisms to really know what the heck is going on within here and how to describe it.
Yeah. I can even add that from my personal experience, it's very clear. I mean, it's more clear than I'm a bit confused about what I feel or something like that. It's really like a whole language is missing. So I am so confused, and I'm sure, Mark, you're going to explain more about that, but I'm using the body language and cognitive language and the whole part of the emotion part, which could be very complex and confusing, is just lacking. So if I can ask a patient, what did you feel in this particular scene? He would have troubles. He would say, I don't know, it was okay. It was confusing. He would not use the word, I was panicking and I felt this huge fear. This would not be a part of the terminology. So you can really sense it when you pay attention to it, and so I completely agree with the definition. Yeah.
You tend to get one of three sorts of answers to that classic therapy question: how do you feel about such and such? Right. The answer could be, the most common answer is a vague statement of feelings: good, bad, stressed.
Yeah.
Sometimes general things like upset, but you're not sure what that means. Or you get another answer, which is how the body is feeling. And my stomach seems to be doing these weird knots. I don't know, something's really tight up here. The body's knots. And the third category of answers is they talk more about their environment. So how do you feel about talking to a whole bunch of people here in Israel or wherever? I hope this Facebook thing's working okay. And there's three boxes right here. Whatever.
No, we stream to this Facebook page where I invite people to come on. And so we invited, and I just invited another doctor because it's a little different way so people can interact. It's not like a Zoom. So do you feel uncomfortable? Are you feeling triggered?
She's asking me about my feelings now.
Because I'm feeling triggered, so I'm projecting it on you.
I was a little bit. I shared with some friends this morning that this format is newer for me. I'm used to having a PowerPoint thing, and I can kind of go from there and interact with the audience. Here I see the two of you. There's some people hiding in the background somewhere.
We're going to do that in a few weeks. We're scheduling again. So.
And you scared me, Tova, when you said this is going to go up on YouTube and it could be seen by huge numbers. It's like, oh crap, how am I looking?
I think first of all, you look great. Second of all, you're among really family. Third of all, you're an emotional guy. When I was talking to Dr. Lumley before about Dr. Schubiner. Now, Dr. Schubiner comes into a workshop and he's like, I just made a mistake and I'm feeling upset. And he's just talking about himself so authentically. How could you not feel comfortable? Yeah. So, what here, it's just really, it's wonderful because what you're telling us is this is how we have to be in a relationship with a doctor or researcher. I mean, one of the world's leading researchers, and I would be initially intimidated by that. And, where you're saying, hey, I just went through this at a young, I was a little boy and I'm a little nervous. I'm a little uncomfortable, and we're expressing ourselves and getting to what we need. So I think this is a great example of how we need to be. But so some people in the audience, not the audience, there's listeners that come into the Facebook page. If you want to share a question or ask anything to Dr. Lumley or Yoav or myself, we're here. That's what I love about the studio. It's a safe place and we interact. So it's not just we're talking we're really sharing. So we're going to interrupt you which is rude, but that's what we do. You interrupt us. So this is interesting about your childhood. I mean, that is so interesting about what happened. Can I just say, how old were you again?
I'm thinking it was about 4th grade in the United States. It was probably 10 years old.
That's really an interesting story. I mean, do you refer back to that often, or you haven't?
Yeah. I mean, it was formative. It was like, I do remember I wonder how much my memory has, reconsolidated over the years and spun a little different story, but I certainly puked in the hallway. That I'm pretty sure happened.
I can share a personal story. My personal journey to the medical psychology world was, again, as a young boy who was very, very nervous before major events, like a field trip or like a holiday or something like that. And again, this really weird sensation in the belly and then to throw up. So my mother used to call it, how do you say? You're emotional, actually. You're emotional. It would be okay. But it was anxiety, actually. So I panicked before a very crowded event or something like that. And I used to, again, so we are connected by puke. I liked it. I like it.
And maybe some intestine stuff in here too. So I better share another story because this is also formative. My teenage years into my even young 20s, I remember anytime I would go on some sort of a weekend event, like with scouts camping or some other event, my intestines would shut down on Friday afternoon and they would reopen come Sunday afternoon when I'm returning home. Usually when I'm within about a quarter of a mile or of driving close to home. The brain knew I'm going to be in an uncomfortable place, intestines, no bowel movements allowed until Sunday when you're close to home and you're in a comfortable place. I don't know if anybody else.
And you had some fear of pooping in the forest.
Yeah. Or just sort of a discomfort in being in a new place and being vulnerable and all that comes with, that. But I was just thinking that you're saying when your mother said, when your mom said you're being emotional, she's right and wrong.
Yeah.
There was emotions certainly involved in that experience, but there also was a part of you not being appropriately emotionally expressive or engaged that led to the somatic reaction.
That's 100%.
I think that she kind of was like, oh, you're being sensitive, you're being emotional, like something's wrong with that, and not being, hey, listen, are you upset? Is something upsetting you? Like no reflective listening happened in that generation. It wasn't our parents' fault.
Yeah. So if my mother is watching, hey, Mom, it's not your fault. We're okay.
We're not here to blame. We're here to be responsible. So go ahead. So you met the psychiatrist. You began to study more of the emotions and pain, and some autoimmune with some students. So because take it further. Then you begin to research in fibromyalgia and expression therapy and emotional awareness. This is a little bit more.
Where the heck did all that come from?
We're talking the Buddha. We're talking the Dalai Lama. And here we're sitting here with a distinguished professor. Go.
Note number 1, distinguished and extinguished are really close together in the alphabet. Okay, so we have to watch ourselves.
Love that humility. Go ahead.
So early on in my career, the early 90s, I'm doing a lot of research on this alexithymia thing and finding that it basically is sort of a risk factor for lots of problems, pain and other sorts of things. Jamie Pennebaker is a psychologist in Texas, and he's doing this work on expressive writing, right? And I, in the mid-90s, started to borrow that and did a whole bunch of studies applying that to people with health problems. He'd been working with mostly healthy young adults and others. And I said, how's it going to work with people with chronic pain or fibromyalgia or other sort of things? So we took that paradigm and we did probably 15 studies on mostly different clinical populations.
And I want to just mention Pennebaker is the utmost authority on expressive writing and journaling. And he's like, David Hanscom brings his work forward, and he's really, that's amazing. So you had a relationship with him.
Yeah.
And wow.
Yeah. And he's also just a wonderful guy and very generative and humble. And one of the things we found was that the expressive writing, two things I realized. People do have a lot of things they hold inside and need to bring forth and share when asked, when invited. They will often share things that they've been struggling in holding back. But the other thing we realized is that the effects of simply expressive writing, in our experiments, we would compare expressive writing to some neutral control writing, and the effects were small. This was not like bang it out of the baseball park, kick the goal, the PK and win at the end of the game sort of stuff. This was small effects. Some people would have nice reactions to it. Lots of people said, I don't know what to write about, or I don't know how to write about it, or I don't know what to do with these feelings, which led us to this next phase in my work. And in this phase, I was introduced to Howard Schubiner. This is probably 2008. A colleague said, Mark, you got to meet this guy. And I did, and we fell in love. Schubiner and I had been working together ever since, and including on a major clinical trial we're doing right now, funded by the federal government here. But Schubiner brought to the table this sort of clinical expertise, frontline work with patients, and a thought, kind of a big picture of what the field is doing, and I really appreciate that. And I brought sort of research expertise and theory and that sort of stuff. And we've made this good couple together. Yeah. And it moved my research into, I don't just want to send people away to do diary, journaling, expressive writing. A quick little side note, by the way, Jamie Pennebaker and some others like Joshua Smythe are social psychologists. They're not clinicians.
Social psychologists.
And there's something attractive about telling patients, go do this thing on your own without a clinician and you'll be healed. You'll be healthier. Yeah. I'm a clinical psychologist. I like to work with patients. And there's a part of me that always said, do they need me if they can send them away and do their writing and their journaling and they'll get better? And so I sort of thought maybe they need more than just go write, don't need me. And so we moved to this other line of research and we started doing work on how do we take the expressive writing idea, share what's going on that you hold back, put it into language, process it, emotionally work it through a bit and see if you can become healthier, but this time being guided by a therapist. Mm-hmm. The same concept, bring in the therapist. And we started to apply this early on with a study of people with fibromyalgia and found some nice benefits of that approach. Howard Schubiner had been working for years in a mind-body approach based on John Sarno's ideas. And so he had developed sort of his own class that he ran, and we tested that class in a couple of studies, and it showed nice effects of his patients. And since then, we've just been sort of developing it and testing, sharing it with the different groups around the nation and the world who are testing these ideas. We had to come up with a name for it, and I know that among you've talked about things like pain reprocessing therapy and emotional awareness expression therapy, just a bit of where that came from. Howard had called his approach Unlearn Your Pain. We wrote a grant saying, let's talk about emotional exposure therapy. And then we started to debate, what are we going to call this? And then another colleague, Alan Gordon, came along and he was working with teaching folks this work. And he said, I want to focus on the pain a little more. And we had a team meeting and Alan came up with, I really want to focus on thinking differently and attributing your pain differently. And he called it, let's call it pain reprocessing therapy. And Howard and I were talking about, we want to call this thing that we focus mostly on the emotions. And I came up with this 4-word thing, emotional awareness and expression therapy. Too many words, by the way, and too many letters. 3 letters, 3 letters is a lot better than these 4 letters I've discovered.
But it's amazing. It's amazing to see here in Israel. I think, Tova, you can maybe say a bit more about that the world of mind-body medicine started pretty much recently with the work of John Sarno, who a couple of his books were translated into Hebrew, then another book by David Clark. Then we got to know Dr. Schubiner's work. And then Alan Gordon came up with the pain reprocessing therapy. And this is, like, I think, the moment to hop on, like to join this amazing journey that this approach is going through. I see also in your papers, there is a lot of, I'm not going to say fight, but there is a lot of comparison with CBT, which was, I think, up until like 15 years ago, the approach for chronic pain used to be pain management, right, with mindfulness techniques and many elements from those approach. But now it started to shift a bit, since we know how the brain works a bit better, and we can suggest methods such as EAET and PRT, and I also recommend about intensive short-term dynamic therapy, which I sometimes use, which is also a lot of initials. You're absolutely right. A lot of initials.
Five initials on that one. Yeah.
Yeah, exactly. So, but this is the journey of the method. And Tova, I think that one of the purpose of this meeting is to, like, say to everybody, clinicians and patients, come on in. There's plenty of room, and we want to grow here in Israel. And to speak with you, it's a great opportunity.
Yeah, I mean, what I'm coming across, because Yoav and I are on the ground, with the patients and the clients, and I'm continually bumping up against, men and women that do not even understand the connection between emotions, feelings, and the brain. So that's one thing. And then, I lean on the journaling and the expressive writing, and I just heard the other day, well, it doesn't work for me. And then, a couple of years ago, I had Nicole Sachs on my show with Michael Galinsky, and I said, why are people not benefiting from journaling? She goes, they're lying to themselves. And that's what she said. They're lying to themselves because there's a level of, like, I'm writing and I'm not connecting. I'm writing and just rationalizing and defending. But I'm seeing, after looking at your stuff, the reality. And when people say to me, well, I haven't done it, I need to do it, I try to give them prompts. I think your workbook is amazing, and I've been sharing it on Facebook. It's, so it's and Unlearn Your Pain, the workbook, it's really heavily with, writing and drawing a circle. And it's like, but you've got to believe that if people do this, they will get to what I call, the nakedness, the naked with your clothes on. Because isn't it about visiting yourself? Like, we write and we visit ourselves. And when we visit ourselves, not only does something happen in our brain, but there becomes an opening, a compassion, a possible gratitude, a forgiveness. And this is another topic, but people are avoiding visiting themselves. And this is the way out. Because when you look at the brain reprocessing therapy, when you look at the fight or flight, when you look at the parasympathetic, it really comes down to this relationship with your brain. And it has to be a love affair. I mean, it sounds mushy. If anyone out there wants to chat, to talk with me about this, it's like, it comes down to, you can't heal a body you hate. The people we've met that have healed cancer and really unbelievable autoimmune things have had to love their tumor. One of the big doctors here, he's an Arab doctor, Dr. Nato Bhutto, says that cancer is a cry of the soul. And he's all over the place with healing through your body, mind. And so I'm getting a little off topic, but I think what I asked you to talk about more is the value of expressive writing. The fact that when we feel this resistance, that means we need to do it. It is not easy. I've been doing it for 40 years, and it is not easy. I keep the book open. I look at it. I doodle, and I'm like, what are you avoiding, Tova? Who are you avoiding, Tova? So This is not an easy thing, but it doesn't mean it's hard. It means just talk a little bit more about, and I do want to, written emotional disclosure, WED, was something out of your book. You actually titled this exposure, this expression. Talk more about how important it is to journal and how we get over that hump, because it's not comfortable.
Yeah. So lots of good ideas that you're generating here. I want to just mention that the work I've done has been mostly in randomized controlled trials. And that differs from clinical practice, because you take people and you tell them you're going to write about this or you're going to write about something else. They're randomly assigned. They got to do it in a certain way. They don't share it with anybody typically. And so those trials, especially when you're comparing it to some other sort of writing, they're not that strong of an effect. Clinically, you have the chance to work with a person much more firsthand. You get to talk about their concerns, their resistances, what they might need. I also think that writing by oneself completely can be useful for some people, but a lot of people need more help. They need somebody else to bounce something off of, to check in with, to explore with. Most of the patients that I see, that we see in our clinical trials, there's a few that can like just do it on their own. Many others need help with that process.
Yeah.
With expressive writing, it sometimes is, what topic should you pick? What emotions should you go for? And then what should you do with the writing? So what I like clinicians to do is to say, will you bring your writing in and next time we meet, and then have a discussion about whether the person, what they should do with it. And by the way, for me, a big motto is encourage people to do the uncomfortable thing. Not what makes you comfortable, Tova. Hey, whatever you're comfortable with, Yohav. It's more like, actually, what would be hard for you, but good for you?
What triggers you? What makes you feel that belly, that breathing stuff?
Yeah, anxiety is a big green light that says go forward. Basically, anxiety. If it comes too much, then you have to sort of pare back. But most people need to be able to experience anxiety, which is a sign that they're going in a good direction. And so when I talk to a patient, I'll say, would it be helpful for you if you read this out loud to me? Or if I read it, which would be maybe harder for you, but better for you? And then do that in session. And oftentimes that thing they wrote then could actually, what would it be like for you to imagine that person, your mother, your father, your sibling is next to you? Could you put that, what you've written, into language towards them right now?
So I completely agree. And I just want to add, in journaling, in expressive writing, and even in questionnaires, sometimes it's so valuable to do the questionnaire with the patient. I mean, to work it and mark it, and then to talk and to discuss about the answer. And I completely agree, although if some of our viewers are not aware, randomized controlled trials are the top quality of research. I mean, it's the best way to conduct any type of research. So yeah, it's not like field clinical work, but it's the close you can get. So you're being very humbled, sir. There.
Yeah, but it is the case.
Yeah.
I've got the slide that I sometimes show, and it's about doing CBT for chronic pain. From the literature, the most recent set of clinical trials, if a patient says to you, hey, Tova, how much will my pain improve if I take a course in CBT rather than just treatment as usual? And the answer is very small improvement compared to treatment as usual, which is what a clinical trial tests compared to another control condition. Patients don't ever ask that question. They ask the question, how much better am I going to be after doing this than I am right now? And that effect is usually bigger, including with expressive writing. So compared to how I am right now, how will I be a month from now after doing this work?
Yeah.
So, but anyway, we don't need to get caught up in the science of all this stuff. The question is, what can we do to help people heal?
Yeah.
And so I actually think that, some people will need help getting past their alexithymia and working on it. Some people need help realizing what they have to do work on. And good therapists will sort of zone in on what is most difficult. And if the patient can handle it emotionally, to sort of go there on that topic.
Yeah. I do want to say something really important. I don't think I've ever said this, but it's such an appropriate thing. And on the record, I'm from Philadelphia, and U of Pennsylvania is where the father of cognitive behavioral therapy, Arne Beck. And so his daughter was a psychologist in my community. And she got more into more the diet, more losing weight, which is never about the food. It's about your relationship with the food. And she has a workbook, a 40-day workbook about writing your feelings, write what you want to eat, what you didn't want to eat, what you thought about eating, what you dreamed about eating, and how you feel about it. And all these it's a wonderful way to drop the weight and keep it off. what's fascinating was also at U of Penn, they did a study on writing down what you eat guarantees you're going to lose the weight. And the further showing someone what you wrote, what you ate, will guarantee like this. And so we're talking about the same thing. Journaling, writing, showing it to your therapist, sharing it, even throwing it out and burning it, which is big on Dr. Hanscom's. And I saw it in your research. It's okay. Like there's no rule. Some people are like, I don't want to dig it up. I don't want to go there. Like everyone has their reasons, their defenses of, I don't want to, but I'm so convinced about this expressive writing and however you want to frame it, write it, color it. You know, there's a YouTube about drawing your vision, like imagining your future and drawing it. But if we don't draw it and implement it, if we don't write it and then go ahead and implement what we felt, so this is part of it. The journaling is a big door open. I just want to share about the research because, you know, we can research feelings and emotions and brain and nerve circuits are able to. And so I'm really pushing to the listeners, and I'm really going to, you know, ask my clients more about journaling and it's such an important tool. And you mentioned Sarno said way in the beginning, and I don't even know if he knew Penny Baker.
I don't think so. Yeah. So in my own career, the journaling, expressive writing piece has just been a step towards a more comprehensive therapy. But it's an important step, and certainly is. The impact can be large because it's easy to do and it's inexpensive. It doesn't require.
So let me jump in before we take some questions. A basic question: why emotional awareness and expression therapy? What is the connection to chronic pain? How does those two things connect? What was the reason? And how does it look when we are if we are patients in your clinic, if we go to this type of therapy, what we would expect? Yeah.
Wonderful. Several pieces that feed into it. There's a long literature showing that adverse childhood experiences, trauma throughout the life course is a risk factor for the development of chronic pain, and worse chronic pain if you've not, if you've had that in your background. PTSD, post-traumatic stress disorder, and chronic pain are really tightly linked, right? Not just people coming back from the war zone, but people coming back from a rape or a whole sorts of other sort of things, right? We've known that for years. None of the therapies over the years have dealt with that. They've just said, well, that may be there, but let's talk about how you can manage your pain, which drove me nuts because it's many other approaches in therapy. We'd say, let's tackle and address those unresolved issues. So I came into this thinking, can we improve chronic pain if we address that stuff in the background? The emotions got involved because there's a lot of evidence that just trying to do cognitive work, and apologies to Aaron Beck, but just trying to do the cognitive work doesn't seem like it's as powerful. There's a lot of research that shows that the most powerful thing, check this out, the most powerful thing that happens in a course of therapy or counseling, the thing that's most predictive of a good outcome is
working the lines. That's
the number one answer on the board, but it's by research, it might not be the most powerful. It's emotional expression. The working alliance, has been studied hundreds and hundreds of times, and it has a nice, solid relationship with a good outcome. But even stronger is the degree to which patients will become emotionally expressive in therapy.
You mean like what Yoav said was the relationship between you and the patient, the client? Was that? But you're saying their ability to express themselves authentically and openly and in a safe way.
Yeah, what actually is measured in these studies is people will watch a recording of a session or listen to the session, and they rate how expressive, how emotional the patient has become. Wow. And the more, the better the outcome.
Amazing.
Most therapy sessions are pretty cognitive. They're pretty chat. They're not very emotional. I mean, right now we don't have a lot of emotionality shown, a little bit of smiles, but we don't have any tears. We don't have any rage going. We don't have any sort of.
Give me a minute. I'll cry in a minute. Give me 1 minute.
I'll help take you there. We'll see if we get there. But on the other hand, if your go-to is crying, then maybe we got to help you access some other feelings.
Yeah, it's funny because Rose, may she rest in peace, my co-host, who was an ISTDP therapist, studied with Alan Abbas. We had Alan Abbas on the show with her. It was amazing. She always says, are they tears of pity or tears of
Grief,
compassion?
Okay.
And it's an interesting thing.
Yeah.
But so again, you're saying that, I'd say it in your words. I like to repeat that what you just said again, please. About the in the therapy session, what's the most
yeah, so this research, if anybody wants to dig into the literature, Peluso and Freund in 2018, they did the big meta-analysis, and they basically found that the more emotional expression the patient has during a session, or patients in given therapy sessions, the more likely they are to have good outcomes.
Wow.
And it's not been studied nearly as much as the Therapeutic or Working Alliance, which has been studied many, many times, and it's a nice thing. But so for me, that became another part of this thing. And then I started looking at other issues, like how do you help people overcome basic fears, phobias, for example? You can't just talk them out of it logically. You have to experience them out of it in their mind or in vivo or in some other way. They have to encounter that which scares them. They become emotional, anxious, fearful, and then it leads to a healing process. How do you help people through post-traumatic stress disorder? Somehow they have to encounter the thing that they've been avoiding, whether in therapy or in their daily life under controlled circumstances.
So do you have people jumping off a chair in your office if they're scared of fight?
I'd rather take them to the top of the building or something and approach them closer.
This is somatic tracking. This is meeting your fear. This is becoming friends with fear.
Overcoming fear is a key piece of this thing. It really holds it together, whether it's fear of your pain and something's wrong with my body, or fear of my spouse, or fear of my memory from that thing that I went through when I was younger. We're really trying to help people overcome their fear and give them the freedom from their fear. It holds it together. How do we do that? Talking people out of it is pretty weak. It doesn't work very well. You somehow have to help them experience their way out of it. And it usually means doing something that's a little hard, but is also healthy. And then when it comes to specific emotions, this is an important piece. And Tova, you were just talking about what types of tears are we talking about? Some emotions are adaptive and fit and need to be accessed and given some expression. And others are more defensive or sidebars or other things that aren't actually helpful. And this is an important piece. So if my student tells me, hey, Mark, my patient got angry in session. Aren't you happy? And I will say, maybe. Is anger a defensive emotion against maybe feeling sad, vulnerable, embarrassed, guilty, and they're getting angry to kind of ward that off? Or is angry a new emotion because it fits their sense of being victimized or treated unjustly?
Yeah.
If the latter, I'm celebrating with you. But if the former, it's like, we've missed the right emotion.
Good point. I mean, I think we all grew up believing that there were positive emotions and negative emotions, which isn't true anymore. The science is that anger is important, and it's the way you express it.
Yeah. For me, anger is the thing I see most commonly as the most messed up emotion in people. It's usually messed up because it's been blocked.
Yeah.
Wow. You and I, we're talking about your name, which in Hebrew means what, from where?
So the origin of my name is actually from the Bible, and Yoav was the Lord of all armies for King David. And before we went live, I said to Mark that my youth rebellion against my parents, who named me after this individual, was to go to the therapy world. To go to the heart and soul, and not to the sword and shield. Other shields.
And when I heard that, I thought somewhere in there is also the warrior who has a sword and a shield, and the therapist who says, I love and I hold, and a person who's a son who says, hold me and love me.
Yeah.
Mom and dad. And they're all there.
Mike, I'm going to cry. We said we're not going there.
Really good analogy.
Would crying be the good emotion, or would it be,
Exactly. Yeah.
Good analogy. And, when we talk to people about like your amygdala processing core emotions, I mean, I would say, fear, anger, shame, guilt, sadness. I would be like, and love also is this emotion that we feel physically, chemically, physiologically. So I never again, this is part of this is a new world for me in my studies since I've, bumped into ICDP and understanding the, because I grew up, trying to be less sensitive, going to many therapists and asking them to help me develop a skin like an alligator, and till one therapist was like, maybe you want to channel this sensitivity. And that's what I'm doing here, channeling my sensitivity. Enough about me. I wanted to bring up Kim's question. It's a good question, Kim. So happy to see you here. Kim lives in Britain, in UK. Okay, so Dan Buglio often says that a lot of the time, your brain is perceiving danger that creates symptoms. How do you journal regarding this? If you know what your brain is fearing, then do you journal about the fear?
I'm going to broaden Kim's great question a bit. I think that just journaling about stressors, or even just processing stressors, however we might do that therapeutically, is a piece of the picture, but it's not the whole thing. When it comes to somatic symptoms like pain, we also need a model that says where the pain's coming from. So I've seen a lot of people, they say, if I just deal with trauma, if I just deal with writing my feelings, then I'll be healthier. And they're not, because I think there's a missing piece. So in our work, we're starting out with, if we want to borrow from pain reprocessing or pain neuroscience work, a good explanation of where your pain's coming from, which is your brain is the pain organ. It registers sensations from bodily tissues, including torn tissues or structural problems or disease processes, but it integrates it with beliefs and fears and expectations and social models, and it creates this thing called pain. And it says your back hurts, your knee hurts, your whatever hurts. And without that story, patients will often still believe something's wrong with my back, my knee, my shoulder, my whatever. They need that story to make sense, I think, of processing any emotional things or dealing with their traumas through writing or through therapy. Because they need to be able to say, I saw a patient the other day and she said, we're running this clinical trial, so we're recording these sessions, 8 sessions of PRT, EAET combined. And one woman said, it's really strange. When I bend down at home and I'm alone or I'm with my daughter, I can bend down without pain. But if my husband's at home, it hurts really bad and I can't bend down. That is, we needed to give her the story of where her pain's coming from. And it's not back, it's brain. And her brain is feeling some threats when husband is home. I wonder if you could imagine what the threat is in the background that makes her feel like she's not bending over around him. He's been cheating, having affairs. She's enraged about it. And she actually came up with the image, I don't want to be submissive and bend down around him. Damn it. But as soon as she said that, she also withdrew from it because she can't be assertive and angry. And she said, something's wrong with me. I shouldn't feel that way, et cetera. So helping a person, realize what's going on in their lives and their background, how it drives their emotional system in their brain. Fears get up. In this case, her fear of finding her strength, her fear of becoming angry, her fear of asserting herself in a relationship, I think drives the pain in her brain, and she experiences it in her body.
Wow.
It's amazing. I think that every single person who watches us right now and live in this world from age 0 is trying to get control over his life. We do it with holidays and working hours and the work-life balance and marriage. And sometimes to switch it, to say to our brain, the reality need to be altered is a very, very challenging thing. My recent metaphor is ChatGPT and the whole AI world, right? So it's the same. We are gathering information, constantly gathering information and producing an output. So we need to learn a new model. We need to bring in new data. But sometimes this data is not very nice. It's not very, just your recent example, it's not, it's overwhelming. And we need to do it again and again, and to provide a safe environment to do it. This is the whole clinical setting and situation. This is the work. So I really like this example because it's an example of a breakthrough, and insight is not always pleasant, but it's important. It's a psychological development, and people sometimes say, oh, like a light bulb. Oh, yes, of course, because my mother didn't feed me broccoli. I understand now. No, it's not like that. It usually comes with pain and loss and a sense of, oh, wow. So that's a very nice and great example.
And what we've learned is that once we get to that aha moment, we got to hang there.
Yeah.
We tend to escape and, okay, I'm done. And so to Kim, I would say that, elaborate on this. This is sort of a simple cheat sheet way to do it. Like, 1, 2, 3. So you know that you feel fear. Fear is usually the trigger, and it's the pain fear cycle. Well, what would be driving that fear? Like, what message would the fear be bringing you? Mm-hmm. You figure that out. And then what deeper emotion, what core emotion might be you feeling behind that fear that might be driving the amygdala to put you in fight or flight to keep that cycle going. So maybe like, and in the Gordon work, remember the evidence, look at the evidence. Nothing's wrong. Had your MRI, been to the doctor. You're not broken. There's no threat. You're feeling threatened. So there's a psychological threat. Okay, so let's go deeper. So what's driving it, and what deep feeling, and then journal about it, meditate about it. I mean, if you need to have a cigarette or a joint, go ahead, but understand that you're calming yourself down with this exterior thing, which I'm not judging, but still you want to be the cigarette, you want to be the nicotine, you want to be the opioid, and you have those chemicals inside of you by a deep breath. So if I go exercise because I'm feeling stressed, I still want to be aware of what's pushing me, because I exercised yesterday. I don't need to do it today. Okay, so I saw something on the news, or I just need to work things out. So it's this acceptance, another level of acceptance, and then stay there, which we tend to be in this doing mode. And I've been writing a lot of things on my Facebook about being and doing. Being is in your parasympathetic, and the doing is your brain, which is we're experts at doing.
Yeah, I'm with you that it's not just a one and done. You need to remain with an experience, and oftentimes continue to encounter it. So the notion of insight, I think that is step one. Repetition, step two. How else can I extend it so I experience this stuff in a different way, in different contexts, in different places with different people often. But one of the interesting battles, though, is how valuable is anger to be accessed and to be experienced and even to be expressed. And this is the one that raises the most alarms in people. When I teach it, there's always people who will chat, sounds like a bad idea. I wouldn't want to do this with my patients. So I actually take people through an exercise where they have to allow themselves to think about their own, some conflict relationship. And part of them is going to be angry, and to actually try to find that anger experience and give it some voice or some expression, even, with their microphones off and their cameras blacked out, but to actually do this work. And people will tell me, I didn't realize that I've got so much feelings here. And I've always been taught, suppress it. And by the way, who's really sort of guilty at this? Those of us who go into the helping professions, who desperately want people to feel calm, comfortable, good, and pleased.
Good point.
And
good point.
And so we often are really uncomfortable with anger within ourselves and in our patients. And we look for ways to quickly transform it, to just meditate about it, switch over to the positive, other sorts of things. When people are afraid, well, first off, they have lots of experiences that they should be able to feel angry about. The victimizations, the injustices, it's there. And to allow them to experience that in a safe place like therapy, or in their own writing, or in their own private car, they're sitting in the pad, whatever it is, not driving, but allow themselves to experience those feelings in a more intense way and overcome the fear of them. Then people will often become much more balanced in terms of finding their assertive, healthy voice in a relationship, or they'll be able to put the anger away so it doesn't haunt them as much and stay rumbling around in the background. But it is the one that we run into the most pushback on, because people they see the destructive consequences of anger, and that's all they can think about. Yeah. You get messages like, don't you do that, put a smile on your face, and don't you be mean, and we especially see it with girls growing into women that are told, no, can't go there.
And
So,
you know,
so
and
I'm,
you ask clients, you know, what are you feeling? I'm feeling frustrated. I'm like, that's not a feeling, and it's all usually anger. Go
Yeah.
ahead. Go ahead.
Yeah, I know Mark just mentioned females and younger women, and you have a fascinating work about fibromyalgia, who is more prevalent with women. And I personally wanted to hear more about that because, in my experience working with fibromyalgia, I'm a a psychologist, and they sit, and usually it's not the first thing they talk about because they have so many other parts that need to be addressed, like recognition and someone to see them because of a whole agony they're going through in the medical system and they get a proper diagnosis. But I would definitely want to hear more about fibromyalgia and the work you do in that area.
So fibromyalgia is, I love it. I think it's a fascinating and a really needed problem. I mean, people that have it have great needs, and it's a tough one to live with because there's so much rejection and invalidation that goes on from the medical community to family members to everybody else because they can't see anything wrong, and how can their whole body be hurting if you could have these other symptoms? I think of it as the sort of ultimate in brain sensitization. The ultimate as in it's often the end result of a series of other things in life. So you look at the person with fibromyalgia, they often had something else going on when they were younger. They had those headaches, they had the bowel issues, they had something. And now that they're 45 or 50, it's become broader and multi-system. But it really is a brain-based problem. And we're not going to be able to track down the pathways really clearly. There's probably variation among patients and the processes. But if we think about it as a brain problem that has been overly sensitized over the course of a life, most of the time, people with fibromyalgia feel stuck, trapped, helpless, blocked, unable to move forward. And successful therapies will try to reverse that and help them see that there can be freedom, movement, growth. Just talked with somebody this morning who telling me about their patient, and they tried to do they ended up having to work with the patient over what do you value, kind of taking from acceptance-based work. What do you value that you want to work towards? And it was bicycling and hiking. And they ended up successful. It took some time to help them move out of their stuck mode, but to continue to push themselves a little bit into new ways of being. And that was helpful for them. We've had other patients where I remember one patient in our trial, our earlier clinical trial, where she was stuck in a really crappy marriage. And every time she tried to make a growth step for herself, she got pushback because her husband didn't want that. And she continued to have suppressed rage towards a bad husband. She, when I followed up with her 6 months later, she says, I am now healthy. I don't have fibromyalgia. I'm not taking any of those medications anymore. What'd you do? I left my husband.
Yeah.
And I'm filing for divorce, and it's about time I do that. And I was sort of mixed. Is that a good outcome? Well, yeah, I think it probably is, even though I'm a fan of marriage. But sometimes you got to do the tough things, and the tough things might be tackling your history of emotions you don't want to deal with. The tough thing might be tackling your boss differently at work or your coworker, and sometimes it's tough for your spouse. I remember having another patient with fibromyalgia, and she was terrified of her mother, who was a strong-minded woman ever since the patient was growing up as a girl. The patient had once told her mother, shut up. At age 19, she got upset with mom, and she said, shut up. And mom said, how dare you talk to me like that? And at that point, the daughter moved out of the house and developed fibromyalgia later and always was intimidated by mom.
Wow.
I had to do some work to get her to start to confront her fear of mom and her fear of using the words shut up around mom. And I convinced the patient to bring mom into the session.
Good idea. Good idea.
We need to do a lot more of this. Mom is a 75-year-old lady who comes in with her 50-year-old daughter. Mom is basically, why am I here? What are you psychologists doing? You know? And I said to mom, you do love your daughter, don't you? Yeah. Would you be willing to help her grow? Because she's sort of stuck. Yeah, I can do that. So it wasn't about mom changing. It was about daughter growing. And I said, daughter, what is it that you need to say to your mom? And daughter's anxious and nervous. And I want to say something, but I'm terrified. Mom says, what are you trying to say to me? Daughter says, I want to tell you to shut up, but I can't do that. And mom said, I don't think I'd like it if you told me to shut up. But you always have been kind of scared, and maybe you need to grow up a little bit. Okay. That's what it took. The daughter to be able to say, I want to say to you, shut up. And mom going, well, maybe. Next week I see daughter. I said, how's it been? She goes, I go over to my mom's house several times a week because she just lives a little bit down. And for the first time in years, I didn't want to run out of the house screaming.
Wow.
In pain. Why not? Did your mom change after our session? No, she's still a bitch. I used the word bitch for the first time. She's still a bitch. But I felt different in my own skin. I didn't feel a need to run. And my pain was much better at the house. Normally it goes through the roof when I'm over at mom's house.
So I want to make a bridge. I want to bridge. And I wrote this question down because there are so many people struggling all over the world. Fibromyalgia is like a fad that is just like a pandemic. It's all over. People are getting it, and the doctors are labeling it. And I'm not bashing doctors at all. But where's the bridge where we can get the doctors to help these clients, to help these patients? Because, and I'm not, take the medicine, do not suffer, but there is such a big psychological component. And so how do you see the future of getting more doctors to say, I want you to see my psychologist buddy down the hall? And like, where do we go? How do we help? This was a big thing with educating the PBDAs, trying to educate the doctors more, trying to educate the patients, to educate your doctors, go into your doctors more, more educated, ask your doctors to come. How do we do this how do we say this?
I had dinner with my son and his wife, Lauren, who's a physician, a resident physician just coming into her own practice. And we had this conversation over the dinner table. And Lauren, my daughter-in-law, who's just out of medical school and residency, said, the pain is in the brain. I just don't know how patients are going to get that. To which I said, are you telling them that? It would really be helpful if the frontline physicians gave a story that wasn't, I can't find anything wrong with your body, or that MRI says this definitely is your problem, and said the brain is the organ of pain. For most chronic pain problems, it's the brain, and your brain has learned that your body is in danger or your life is in danger, and I think those things end up causing your back pain or your fibromyalgia. It is your brain. It's not like crazy. It's like, this is the way brains operate, protection of the body and the self. And you've had some threats in your life, both to your body, that injury you had, and other threats, some of the stuff you've been through as a human. And I think your brain has become sensitized now and has sort of turned up the alarm system. So if we could get physicians in the front line to start communicating that message, it doesn't take but a minute or two. If they were to take it another step, it wouldn't be refer to psychologists, because I don't know about you all in Israel, but here there's not nearly enough people to help. I would love to see somebody in the frontline medical setting just spend a little bit of time with the patient, for example, going over ACEs. I don't know if ACEs are being used as a screening instrument.
We all know about it here. It's very important.
What ought to be done, and I think David Clark said this as well, just sit down and kind of go through the checklist with the patient. It doesn't open a Pandora's box of this is, oh my God, this is going to be therapy for years. Just having people share a little bit of the story. Like, so what happened to you? And is this still bothering you now? All right, let's go to the next
flyer in the waiting room of the doctor's office. Could it be a little pamphlet?
That would help. There could be other staff members or something who spend a little more time with a patient, just going through stuff to kind of reinforce the idea that your life and your history and what's going on through your brain matters to the rest of you. And that story, by the way, we're finding in our clinical trial, and I'm talking to others doing this work, giving them a new story of where the pain's coming from and making a few links. Many patients, a third to half of the patients, their pain is dropping like a rock just after that new story. They're going like,
unbelievable.
I saw this guy 2 days ago on his first session. He said, I've been struggling with back pain, neck pain for about 3-4 years. What's been going on in your life? Well, yeah, I got a divorce, then I had another relationship, and that person broke up with me, and my mom died during COVID. He didn't make any connections. The therapist shows a little slide of a picture showing the research on social rejection and pain, and that if people feel socially rejected, their brain lights up in certain regions, and if they feel bodily pain, their brain lights up in the same regions. And just showing this little picture, the guy went, oh my God. My pain is because I've been feeling socially rejected. And he starts to cry. He goes, these losses actually are driving my pain, And that little piece, he said he felt his pain go up a little bit when he realized that. Then as he started to say it, he felt his pain going down in his back. And we've only seen him one session. I'm going to have 8 sessions in total in this therapy. So I'm waiting to see what unfolds. But that sort of capacity in a very brief sort of new way of thinking about stuff is unlocking for people new ways of being and new connections. And that can be done in shorter order than we're currently doing it. You know?
That's amazing. Tova, how much time do we have left?
We have another 10 minutes. Go ahead.
Okay, because
express yourself, Johan. Get it all out here.
All the rage. No, rage not. But yeah. So my question is about the placebo effect, which is a crucial aspect, in my perspective, in this whole communication between physician and the patient. Right now, I'm reading Joe Dispenza's book about you are the placebo.
You are the placebo.
You are the placebo. Fascinating work, because when a physician is telling the patient your pain is in your brain and this is how it works, it would go through much more smoother than a clinician, than a therapist. So how do you do that? How do you navigate through the complex work of time and money in the medicine world? You know, in Israel, I think family physicians has something like 10 minutes with a patient and like fully booked schedule. They need to like address the most pressing issues. My sister is a family physician, so I know it from very close encounter. So how do you do it? How do you develop this type of training or awareness, not the emotional part, but the diagnostical part in the physician's world, and the communication with psychologists for us?
Yeah. I wish I had solutions to the healthcare problems that haunt us. And it's tough. And I feel for my physician colleagues who don't have the time and are squeezed into little 10-minute boxes. I do think that it's going to be a broader cultural thing. It's doing live Facebook streams to people. It's doing YouTube things. It's medical schools increasingly teaching their students. Somewhere, my daughter-in-law, who's just out of medical school, heard the message.
Yeah.
And I don't think it was from Uncle Mark. I think it was from, her father-in-law, Mark. It was from somewheres in her training. So the message is getting out there. And I think that it's going to be a cultural thing that's going to slowly start to take over. I'm training, Howard and I are training scores and scores of professionals in these other models, and Alan Gordon's work on the PRT doing the same thing.
Yeah.
So I think it's going to be a cultural shift that's slowly going to happen. There'll be a tipping point maybe where people saying, your pain is actually more in your brain rather than your back. And now we're fighting against the powers that be that make money by doing scans of the bodies and find, when I heard the other day that somebody's got a new lead on doing a full body scan to find everything wrong. Oh, it sent shivers through me to think about what they're going to find, which will then have to be fixed by somebody, and not a good idea.
No, it's an amazing topic. And I listen, I would bring you on once a month with Yohav, and we could the placebo, the nocebo. I mean,
so much
lots of different things that, like, maybe we can talk to your wife and your boss and your psychology department and get you, because this is the answer. This is the answer. We're educating, we're inspiring, we're motivating, we're getting out there. I mean, it is really like, this is my love-hate relationship with social media. But let's think about that, because you have so much to say, and you're saying it in such a beautiful way, a basic way. And I'm really loving this conversation. And Tim, I don't know you, but I'm happy to meet you. And let's, can you read that question, Mark?
Yeah, vulnerability with and trusting in others are very challenging to live without fear because of a perceived threat to being accepted. Suppressing and isolating those feelings are the keep the peace response that feels like the safer option to being invalidated and gaslighted, etc. How do you journal these emotions when your fear overrides sharing these feelings of being rejected? That sensitivity to I'll be invalidated, rejected is a key reason that people keep shut down. And so many people in our lives get nervous about sharing. They would rather maybe not hear it. So, I mean, journaling can be a start, but I would start to encourage people to risk, and it feels like a risk. Tim, you're going to feel risky here. And I bet you, so I'm going to dare you, Tim. Try to find somebody you think might be open to hearing part of your story. And my dare is that you will be pleasantly surprised by the outcome. That's my bet. You'll come back and you'll say, I was scared. I thought it would go bad, and it wasn't as bad as I feared. It wasn't as bad as I feared is gold, and it happens a lot when people start to face some of the things that scare them.
Yeah.
So I won't be accepted. I'll be ashamed. I'll be rejected. I'll be invalidated. That might happen some places, some people, but more often than not, you might be pleasantly surprised.
Yeah. And, we give fear a lot of power. I read something once where we have to walk into it with the fear. Like we give fear this power to hurt us. And it's a thought, it's an energy, really. We talk about the quantum world. And, there's real threats and there's real fears, but most of these are perceived, as you said, Tim, so brilliantly. So, oh my God, I'm thinking of all these different topics.
We could go on a long time with lots of great stuff here.
But I want to say something about, because if anybody's interested, I've been posting it, but I will post the workbook for clients of EAET,
Emotional awareness and expression therapy. I wish I wouldn't have named it that.
No, I like it. I happen to like it. And there's also a workbook, a PDF on your bio, Wayne State University, something green with a I think a shield. There's a workbook for therapists, and I've been reading through them. They're brilliantly done, well spoken, not so wordy, not so contentful. And there was something you wrote, and I think this is probably the real problem is not the stress; it is how we handle it. And this, we know this, Doc. Yeah, I know it, but it's really speaking about. And then you wrote, you get an opportunity to change your experience. So we really get to have, it's not the trauma, it's our relationship with it. It's our memory of it. It's not the trauma. The trauma's not happening anymore. You're safe now. You've already, you're rescued and you've reclaimed yourself. But here's this, so we get to have a new experience, but you have to choose that. That's you being the navigator. You're going to have to decide to be uncomfortable.
Yep. And it is scary. And by the way, we clinicians, if there's us, and we have to decide whether we're going to side with the person's fear or with the person's courage. Right now, they're often stuck. And like when Tim said to me, "It's scary," I said, "Tim, I dare you," which also communicated, I think it's going to be okay. You can handle it. It'll be all right. And I would ask all of us clinicians to look in the mirror and see whether we say things like, "You're right, this is scary. Let's wait till you feel more safe." Or, "You don't need to talk about it. That's okay, because this could be upsetting." Or, "Only if you're comfortable, but if you're uncomfortable, don't." Oh, I think actually that could be the wrong message. We need to actually side with the part of them that's growth oriented, that's courageous, that will help them to grow rather than stay stuck.
And you got 6 hands here, Tim, with you, walking with you. If you can just imagine, we're not fishing for you. We will ask you to fish yourself, but we're right here with you, supporting you, and kind of asking you to be your own cheerleader. But we're here, cheerleading you. We're your team.
Go Tim. Go Tim.
Team Tim. Yep.
Any parting words? Like I was doing this in Hebrew for a couple of years with a co-host. I wasn't speaking too much. I was smiling a lot. My Hebrew isn't so good, but she'd always say at the end, it was very clever. And I started to, and I remember this, and I'd like Yoav and Dr. Lumley to Lumley.
Mark works also.
Mark, yeah, I love that. And I'd love you to leave. What do you want? I'd like to leave tools and tips and take home, and go ahead. You can do this. This is really self-healing. We're just messengers here. So what would each of you like to leave with our listeners? There was a number of listeners in the audience, and then I'm going to put this up on our YouTube and make you even more famous. But what would you like to leave the listeners in the studio, and for the YouTube listeners, what would you like to leave with them?
Yeah. So I guess. Yeah, I'm going to jump ahead, give you the final words. We are human beings, not human doings. So sometimes we are used to do it, but sometimes in crucial moments in our lives, we need to be with a certain experience, even if it's not positive, if it's not pleasant, because in our nature, we are human beings. Okay, that's it for me.
That's beautiful.
Yeah.
I was just thinking, I don't know that I have a nice closing summary like that. I need to come up with one.
We're patient. We have patience.
I mean, the thing that came to mind is doing the thing that's scary is usually the best thing.
Wow.
Yeah.
And when you breathe with and this I did learn in chiropractic school 40 years ago, that exhale, that deep exhale activates a pharmacy, opioids, endorphins, heroin, anti-inflammatory, anti-anxiety, just inside of you. It's amazing. I didn't even know what the vagus nerve was in chiropractic school. It's fascinating to me, the exhale and all the yoga I did. I never understood it until pain reprocessing therapy and somatic tracking. Isn't it fascinating about the breath? And we're doing it all the time.
Yeah.
We can access that anytime, our own inner pharmacy.
Preceding your was breath holding, though, which was also be mindful of something was holding back before the release. And so, yeah, it'd be nice if we didn't have to do so many because we didn't have so many holding back in the first place,
I love it. So here's to the doctor in all of us, and to the doctor and the therapist in all of us.
Here, here.
We send you blessings from Israel, from Detroit, Michigan, and we will meet again. Remember these faces. I'm going to invite you back again, maybe in the end of the summer, to talk more. There's so much work there, and I'm privileged. And I thank you, Yoav. You always have my back. I thank you, Yoav.
Sure, Tova, thank you. Heart to heart, and Dr. Lumley, it's an honor to speak and meet and learn from you. Besides the research and the papers and everything. So thank you so much.
I want to thank both of you, both sides, because I'm seeing then both sides of you. Thank you for the time today and the opportunity to speak with you and anybody else out there. Really appreciate it.
Have a wonderful rest of the day. Erev Tov, Yoav. We'll see each other soon. Good night and God bless.
God bless.
Good night, everybody.
Okay, wait a second. 1, 2, 3,